our agenda for today, I'm going to do a brief overview about direct primary care. I realize probably a lot of you are looking at direct primary care, know about it if you're on our webinar, but just in case there's somebody out there who is brand new to the direct primary care concept, I'll do a brief review here on what that is. Jason and I will go through and talk about our launch process here at Freedom Healthworks and kind of what we generally do start to finish. And then we'll explore some special scenarios of kind of maybe some circumstances that might be a little bit outside the mold of our general launch process. A little bit about myself. I'm a family doctor trained here in the Indianapolis area and worked with one of our local hospital networks for several years. Back in 2015, I left and spent some time with an employer-based primary care clinic and got a little taste in providing primary care outside of the insurance framework. And then about 2 years ago, a little over 2 years ago, opened my own direct primary care practice here in Fishers, which is a suburb of Indianapolis, and have been practicing there ever since. And have this year been working with Freedom Healthworks as the medical director, really trying to drive and expand the direct primary care movement. And I'll let Jason, who's on here, introduce himself.
Yeah, hi everybody. Glad to be doing another webinar. So my name is Jason Rutt. Some of you may know me, some of you may not. So my title is Partnerships and Growth with Freedom Healthworks. And so I've been with Freedom Healthworks since the beginning, really trying to spread the DPC movement and figure out ways to help accelerate and strengthen the movement as well. But prior to Freedom Healthworks, I was total, I have about 15 years in healthcare and startups, with 10 of those years being with United Healthcare. So on the insurance side. So it's on the individual insurance side, a little bit different than the insurance that we'll be talking about today with employer groups. But that's my background.
All right, well, sounds good. Well, I'm going to delve a little bit into what direct primary care is and some of the background with that. So direct primary care, it's a primary care model where physicians work directly with patients without the influence of insurance companies or third-party payers. And for the most part, that care is provided in a membership-based model where most of the primary care services are covered for a fixed cost. And so what that does is it allows us to move away from the fee-for-service or transactional nature of primary care and allows us to focus more on memberships and relationships. The care in a traditional setting is often fragmented, multiple providers, multiple locations. We try to focus on providing holistic care where we get most of the care all in our one office. The care is often traditional, reliant on insurance billing and insurance codes, and direct primary care allows us to innovate a little bit more and really focus on cost savings for the patient. Some of the innovations that we can do in direct primary care, a lot of them involve technology. So e-visits, telehealth, mobile communications are all different aspects of what we do. We can innovate in how we provide care in our office. So doing group visits. I know that's not a new concept, but it has always been challenging with insurance billing. So a little bit easier to do in a direct primary care setting. And then also ancillary services, things that we do in our office. So whether it's in-office testing or labs, those types of things, different procedures that we may provide in the office, and then really even delving into education and counseling. Again, oftentimes things that patients need that may not be covered or may be hard to pay for, but we're able to offer those in a direct primary care office there. When we look at some of the results, this is the Q-Lion study that was published a few years ago, and there's some newer studies that are coming out with some of our newer groups working with employers. But what you really see is a lot of reduction in some of the downstream drivers of healthcare costs. So surgeries, specialty visits, ER visits, hospitalizations, and that makes sense. I think we all know that when you have good access to primary care, you're really going to have healthier people and be able to take care of them at a lower cost. So ultimately, direct primary care, we're providing high quality care as we always want to, increasing flexibility, saving time and money, and then also improving patient and provider satisfaction along the way. So definitely a great way to provide primary care. So where does Freedom Healthworks come in? So our mission here at Freedom Healthworks is to build a direct primary care ecosystem that allows physicians and consumers to thrive in a personal and high value approach to primary care. So what we essentially do is work with physicians and practices through the entire process, from launch to growing your practice to nurturing your practice once it's mature. And we have a number of areas that we focus on, whether they're group services, analytics, peer support, training and operations, or coordination of care. So we're going to focus on the launch process today, but Jason, I don't know if you had anything else to add about some of the big ticket things that we do here.
Yeah, so, and probably for future webinars, we'll talk about some of these other aspects. But the launch process is a roughly a fairly quick process for us to help get the practices up and running and create that baseline that we can help those practices grow. And then I know in the last webinar we talked about some of these other things as well, but we'll kind of touch on those as time goes on. But yeah, we'll just continue on with the launch.
All right, well, sounds good. Well, let's get started. So how do we launch a practice here at Freedom Healthworks? I think the first thing, which some of you may have already been thinking about as if you're back in your current practice thinking about, I would love to do direct primary care, is really thinking about what type of physician do you want to be or what type of office do you want to have? And this is kind of that big kind of pie in that sky aspirational process that I really encourage all of you to do ahead of time to figure out what is it, what does your ideal practice look like? So this may be even going back to when we started medical school. We really have this drive to help people and really be pillars in our community and take care of populations of people. And so this is your chance as you're opening your own direct primary care office to really mold that office to what you want it to be. So the type of patients you want to take care of, the types of services you want to provide, what are some of the guiding values that may drive how you implement your practice. And I really encourage physicians to take some time with this. Talk to your spouse or partner, talk to your colleagues, talk to your family. They know you, and they kind of, a lot of people know what you strive to be as a physician. And so I think it's important to get that input. And this is important to get down because once you start making all the other decisions in your practice, which we'll go through, this is going to serve as the template. This is going to serve as as kind of the source of truth, if you will, as to how you're going to make all these decisions. So Jason, I know you've worked with a lot of physicians starting up, and I think this is something you would agree with as well.
Yeah, I mean, often it's a challenge when you pose this question to a physician because their frame of reference is the traditional health system, and DPC is truly a clean slate process. And it really needs to start with the personality of the physician and what their interests are and maybe what they have always wanted to accomplish within healthcare. And so it opens up a lot more possibilities. And we kind of take the process of helping that physician open it up. And as we launch more and more practices, we have more options that open up and more I guess more precedent for other physicians to look at what other doctors have created. This is part of what's most exciting to me, and it's almost like we help build startup businesses over and over again, but each one is a little bit different. And so it's always fun as I'm working with physicians to see kind of where this goes, where this process goes, because it's not always what you expect it to go. And so that's part of the experience of direct primary care is everyone's different, and I think that's a good thing.
Yep, I think you see a lot of forums that people would say if you've seen one direct primary care practice, you've seen one direct primary care practice. So they are all very different. So I think this is a good place to start. I think one of the next things that goes right along with that is naming your practice. And this is really kind of becoming your identity. So just a few examples. These are practices here in the Indianapolis area that we work with. So one could be a location. So Westfield is a suburb here in Indianapolis. My practice is called Fisher's Direct Family Care. So Fisher's is another suburb of Indianapolis. So you can kind of use a location or a geography as part of the name of the practice. You can use your name. Dr. Schuster is a DO physician here in the Indianapolis area, so he named his practice Schuster Family Medicine Osteopathic Care, or just some other name. So Dr. Daniel Stock is a functional medicine doctor here that we work with, and so he just wanted to go with Pure Health Functional Family Medicine. So really kind of a lot of options to name your practice. So Jason, any comments about that?
No, I mean, again, this is part of the whole process, and we see again, every practice is different and their branding's different, and that's all part of it. It's all foundational elements of what the practice will become as we launch and grow that practice.
Sure. So we've kind of talked about what our practice is going to be. Maybe you've got a name. Then you got to get some business stuff out of the way. This is stuff that we will 100% say that Jason and I are not experts in this, but we have some partners that we work with that will get you through this. But creating an entity, so you need to create a business unit, and there are probably pros and cons for different types: LLC, S corp, sole proprietor. I am definitely not an expert on those types of things, but we can walk you through kind of figuring out what's the best business entity to create. You want to think a little bit about the capital, the financing when you start your practice. There's going to be a little bit of upfront cost. to open your practice, whether it's equipment, some furniture, maybe just some of the initial costs to get started. And then thinking about some of the ongoing stuff as well. As the practice opens its doors, you're going to have some monthly costs that are associated as well. And so, how are we going to fund that? Are you going to take out a loan? Do we have some savings set aside for this? Are you planning on moonlighting a little bit, maybe along the side as your practice grows? So it's important to kind of think about that. And then finally, some of the legal things. So just making sure when we look at the insurance that you'll need, not only malpractice insurance, but business insurance, looking at the patient contracts that we're going to use, and looking at things like, are you opting out of Medicare? Are you clear of all of your insurance contracts that you may have had from your employee position? So just kind of looking through those things and making sure all that stuff is tidied up. Definitely not the most exciting part of the launch process, but definitely a needed thing. So, Jason, any advice that you have from this, and as you've been working with physicians?
Yeah, I mean, it all depends on the physician situation. So the one I'm working through right now is on the capital side. So we're launching some practices in a new market, which is Charlotte, North Carolina. And so some of the physicians may require some capital, but what we're looking for in that case is partners that can provide, that we can build a relationship with, that understand the model, that can provide really flexible terms for the physicians as they're going through this process, and make sure the terms are beneficial. And we do that by providing our capital partners, banks, with sample financials based on what we've learned with the practices that have launched so far. And so that helps. That really helps kind of smooth the process out for physicians as they're launching. We can insert the kind of the capital element within their launch process, whether or not they need build out for their space or just want some extra padding as they're ramping up their practice. And so that's a big part of it. And then on the legal side too, so part of, and again, this is all different depending on the physician, but helping kind of steer those physicians through their insurance contracts, their Medicare contracts, making sure that they have patient contracts that are set within Hint or whatever program they're going to be using. And so it's all part of that, not very exciting part, but kind of necessary as these practices are creating themselves. So yeah, so that those are the three kind of three elements that are very important to starting a practice.
Yeah, definitely. So, like I said, not too enthralling, but definitely required. So,
Well, I don't find it very interesting, but other people.
Um, but then we do move on to some fun stuff. So once you've got that out of the way, you've got your name, you've kind of created your business unit. It's really time to start branding your practice. And this is where I think, Jason, you'd kind of say that a lot of the personality comes through. So thinking about your logo, your tagline, kind of maybe some of the catch lines that you want to do, maybe building a mission statement for your practice. And I think once you have that, then really going into social media accounts, building your website, really trying to create your online presence for your office. And what I think we've seen, and maybe Jason can expand on this, is even if you're not ready to open right away, maybe you're thinking it's now November of 19, maybe I want to open in the spring of 2020, go ahead and start doing some of this, because the more you're able to get your name and your brand out there, whether it's through a website, whether it's through social media, you start to build a little bit of brand awareness, or get some eyeballs on your practice, even if you may not know exactly where it's going to be or when you're going to open, but kind of starting some of that early. And maybe you have like a wait list that you can put on your website to get people that just kind of are generally interested, get them to sign up and just kind of tag along and follow along with your journey. I think
Yeah,
it'd be a good thing to do early.
I think time is always your friend with this, especially if you're a startup practice, is really start getting the word and planting those seeds early. And we can definitely help with that as far as lead capture process. So if you wanted to establish a website, say months, prior to your practice opening, and have a set date for that practice, or opening spring of 2020, something like that. Even before we do anything else, it's really starting the branding process and starting to capture interest in the practice, and trying to draw traffic to that website. And at that point, getting people to sign up and saying, "Hey, I'm interested. I'm raising my hand and interested in this practice. So when you're ready to go, we perhaps could have somebody to market to and contact, and then at that point, get them to sign up as part of the practice and get you a little bit of a head start."
Yep, I think that's always a good thing to maybe not start right from scratch. So I think then you get into a little bit of the nitty gritty stuff here. So as we have kind of defined our online presence, once we're getting close to say, hey, maybe I've got a date that I want to open, we need to find a physical location. So this can be a variety of things. We've seen it all over the board. Some people will purchase or buy a physical location for themselves. It's very common to rent, get a lease for some office space or a location. Or if you're really starting small, maybe you can rent just a room or two from another physician office, another maybe a chiropractor, physical therapy, whatever. Say, hey, you know what? Can I just have a room for a couple half days a week to get myself started? And that will be a great way to go. So once you kind of have that, then you kind of look at some office equipment, medical equipment. And I think the key here, one thing that we kind of preach is really to keep your overhead low when you first start. So you don't need the most fancy equipment. You don't need the most cutting edge office equipment. Just start with some basic stuff to get you going. Over time, you can always add things to your location, but you don't need it to be fully equipped and very fancy on day one. So Jason, I know you've worked a lot with physicians finding locations, so I'm sure you got a little bit of advice on this as well.
Yeah, and really what it comes down to is picking the appropriate space and making sure that cost is in line with kind of the financials of the practice and the budget that's kind of outlined in our process. And this could be challenging at times because the inventory for a space in the 1,000 square foot range, which is appropriate for a DPC practice, is sometimes a little bit thin. And so the sooner we can get started on this process, the better. And we work through partners of ours um, and on the commercial real estate side that we help guide them just as much as anybody else. We guide them on what they should be looking for. And so we've seen physicians that have purchased locations, purchased small houses that are zoned commercial and outfitted those as their practice. We've seen people lease locations. And the important thing about locations is making sure it fits for the practice. And it doesn't need to be necessarily have be extremely visible, but it needs to be easy for your patients to find you. These practices don't generate a ton of foot traffic, so it's really kind of on the digital side that attracts people to the location. So that's what's most important. This process can be kind of lengthy in some cases as you're going through the search, finding a location, negotiating those leases, and then executing on that contract and then moving in. So, in some cases, I speak to physicians that are wanting to get started as soon as possible, and but if you leave yourself some time, um, I would start this process sooner than later because sometimes it can be a little bit lengthy.
Yep, so definitely an important part though. The other part that goes along with that is getting our software systems. So we have a number of software that once you are open and running, we'll need to use. So the crux of everything is really your billing system. So being able to kind of run those monthly membership fees, run some of the one-off fees that you may have, and being able to manage that routinely. We have you'll need an EHR of some type to kind of do your simple documentation. And I know everyone has their kind of love-hate relationship with EHRs, but in the direct primary care model, when we're not doing insurance billing and we don't have meaningful use to worry about, you don't have to worry about how many bullet points you've checked off. It really makes it much more simple. So a lot of the systems out there are very smooth and easy to use. You may have some other ancillaries around that. For example, if you're doing medication dispensing, you may need some software for that. And the other big thing that I think is really important in direct primary care is having some type of telemedicine app or platform. And that may involve your telephones and faxes and stuff like that as well. But having a unified system to be able to communicate with patients remotely, because that is a large part of what we do in direct primary care, is being able to provide those telemedicine and e-visit options for our patients. They don't have to physically come into the office all the time. So I think getting these systems defined, whether it's with pricing, we do have some systems that we work with here directly. Jason, I know if you want to talk briefly about how we use those together to do some of the analytics behind our practices, but I think it's important to start thinking about that early.
Yeah, I mean, there's a rhyme and reason why we chose the software that we chose. And when I say we are a very physician-centric organization. So, it had to have had buy-in from all of our physicians as we selected these systems. But really what that's for is to build off that in the future. So as we work with employer groups, and then for us to provide visibility in the practice and help anticipate any problems, that gives us using those systems paired with our data partner really gives us a lot of data, a lot of feedback on the practice. That's not only shared with us, but also given to the physician as well, so they can have some really good insight in their practice and understand how it's functioning, how their front office staff is doing, um, and give them some direction so they're not in the dark all the time.
Yep, and I think I'm sure a lot of physicians, even on the webinar today, we've been through EHR transitions, and that's never fun. So this is a time, like Jason talked about, having a clean slate from the beginning. So really vetting those software systems early and picking the right ones for your office and what you're anticipating doing. So hopefully there won't be any changes down the line, but that's what we can always try to shoot for. All right, let's talk about staff. So we've kind of, let's say we're getting close to being open. We've got a lot of that location stuff out of the way. We've picked our systems. We're ready to go. Do we need staff? So this is always a question we get. And I'll be the first one to say that I was a little guilty as charged of thinking I needed more staff than I actually needed when I first opened my practice. I think a lot of physicians, when you open a direct primary care practice, and it may depend on your circumstances, really don't need staff on day one. If you're growing, a lot of the things that you would think of your staff to do, whether it's answering the telephone calls, scheduling patients, rooming patients, taking vitals, you can do that yourself, especially when you're first starting out. As you then grow and you kind of get to the point where we do need some staff, some of the things you can think about is obviously we can hire somebody directly that would work in our office. We can contract with maybe some agencies that may provide maybe part-time or kind of a rotating pool of staff members. There's also a number of companies that are coming out with virtual staff members. So what that would mean is maybe there's a nurse and they don't have to be anywhere close to you remotely or geographically, but they would maybe route the phones through their service. So those staff members would answer the calls for you, schedule patients, maybe they do refill requests, maybe do prior authorizations, can handle some of the triaging of patient complaints. And so kind of frees you up to just to see the patients physically in your office, but you have a virtual staff member that is taking care of things from the telephones and maybe through some of the electronic messaging. So that's an option as well. So obviously limiting that they can't physically be in the office with you, but maybe a cheaper alternative to hiring somebody on day one or early on. And then looking at if you are bringing somebody into the office, what level of training do you need? So an MA versus an LPN versus an RN all have their advantages and disadvantages, maybe from a skill set level versus a cost that you would have to pay them. But I think, again, for your practice, you're thinking about what you do in the office, whether you're drawing blood in the office, whether you're dispensing medications, doing other procedures, you got to think about who's the right person to bring into your office at that time. So Jason, have you seen any of these other models in play of kind of covering staff in the offices?
Well, I mean, one thing I wanted to add too is that the selection process when we chose our systems and everything that we do is really to reduce the amount of time spent on things outside of patient care. And so that's really important especially to startup practices, that hiring a staff member at the point of launch is expensive. It's their biggest expense, so it kind of throws their expenses out of whack while the practice is rolling up. So part of it is making sure that things are all integrated and things are simple. And we've had physicians that have started from scratch that have been able to handle the entire, handle the duties of their front office staff, as well as see patients well into the 100 patient range. Now, once you get that, it depends on the comfortability of the physician. But once you get there, then it's maybe time to start transitioning to, hiring someone at least part-time. And so kind of all that we do again through this process is make sure that, we're able to make the practice financially viable in the short term as it's launching, as it's ramping up. And again, that's really important to those physicians that are starting from scratch, is to make sure they have the longest runway possible as the practice is ramping up with patients.
Yep. So those are all things to consider as we're starting up here. So Next, we would talk about enhancing our practice with other items. So as we are getting close to opening, maybe looking at some of the ancillary services that we may provide in the office. So this could be such things like labs, dispensing medications, vaccines, those types of things, really trying to arrange how are we going to account for those types of things. Looking at some of the testing equipment that we may have, EKG machines, spirometers, those types of things, point of care testing. And I think one of the things to think about here is we don't need all this equipment on day one. Just from an overhead standpoint, if we don't have a lot of patients to start with, maybe I don't need a spirometer right away. So take some time and think about the things that you would want to have, and then think about what are the metrics that I'm going to follow. Maybe it's a patient volume, maybe it's just I'm going to wait 6 months and then kind of add those things into the office. And then same thing with procedural things. So whether it's skin procedures, cosmetic type things, GYN procedures, these are all things that you want to, you're trained to do and want to do for your patients. Think about how to integrate that into your office. And similarly, you may not need to offer all of these things on day one, so don't need to go out and purchase a ton of equipment to do some of these procedures. Maybe think about as your patient volume increases, or as your patients need some of these services, you can then order that equipment, get that in, and start doing that. So I think just a great way of enhancing your practice and kind of really making it your own, and bringing value to your patients to be able to offer this. Jason, anything, comments you want to add about this?
I don't have a whole lot, but I'll just add this. So, all of this is part of the process of launching it's really defined within our process of launching a practice. So, early on when we're understanding what the physician wants to do, that maybe give us clues of what equipment they'll need. Now there's a standard set of things that they'll need, but we're able to communicate that to our partners with McKesson or Henry Schein, to be able to let them know of what's going to be needed, and then everything kind of comes full circle at that point. So it's all a very integrated process to be able to not only determine what equipment's needed, but then take advantage of our partnerships with some of these other organizations to actually purchase that equipment.
Yep, so I think it's definitely important. And I think one of the last things then is, as we're getting ready to open, we got to find some patients. So maybe we've been doing some of this already. Maybe we've had that web presence, that social media presence early on, but as we are now getting ready to open, maybe we have some firm dates of we're going to open on this date, here's our location. We've got to get the word out. So what we have done is, sometimes when you think of some of the traditional marketing avenues, whether it's print marketing, TV or radio ads, we have found that they may not be the most cost effective when it comes to getting that return, getting those patients in your office. So what we will do is actually look at your geographic area, your footprint, your market share, that type of thing, and really figure out what is the most cost-effective manner for you to market to your patients to get those new patients. Oftentimes it may be involving some of the local business groups, so that may be like a chamber of commerce or a networking group, and even some community events. I know early on, my first year, we did a lot of farmers markets around our community. I still do sponsor some of the youth rec leagues for soccer teams, softball leagues, that type of thing. So it's really kind of just anything we can do to get our name out there, talking with other business leaders, talking with people in the community to kind of let people know, hey, this is a new clinic or new office that we have here. It's a different concept. Come check us out. Jason, I know you've done this with a lot of physicians, so I'm sure you've got some advice on this process as well.
Yeah, this really varies depending on the presence of the physician, the location where the practice is. Marketing is a very open term. So that could be social media, it could be a lot of different things. It could be purchasing ads. All of these things work together. So especially for a startup practice, it's important for a doctor to kind of have the mindset to be able to go out there and talk with people within their community. These practices, so DPC practices, are hyper localized, and so and actually they work really well in rural areas. So because you're kind of a big fish in a small pond, and you have access to maybe those other people in your community to kind of spread the word, and you're providing maybe an option for healthcare that maybe is not there currently. But all those things are important, and as a DPC physician, you have to think about how to promote your business, because social media, the digital things will get you so far, but working in tandem as a whole really help accelerate things to help the growth of the practice.
Yep. So that's kind of the kind of last step there. So that's kind of the general launch process, start to finish. if you do have questions, again, feel free to leave some questions in the Q&A section. We'll have some time here in a few minutes to go through some of those. We're going to move on to some of these special situations. So Jason has worked with a lot of practices that are in this situation. So I'm going to turn it over to him to kind of follow up on some of these specific situations that we may have.
Yeah. So the first one we're going to talk about now is really converting an existing practice. This is really a situation where maybe there's an independent physician, which is kind of a really rare thing nowadays, but having an independent physician want to transition that practice to DPC. They do that for a number of reasons. Number one is just to regain the work-life balance. And I think there's a reason why there's very few independent practices now, is because the requirements of those practices are so great. The overhead is so much, it's really hard to keep those practices going. And it's very attractive at that point to sell to kind of a large healthcare system, which is what's happening currently. But we have worked with physicians that want to maintain independence, love their patient base, and want to regain that work-life balance again. And direct primary care is absolutely an unbelievable way to be able to accomplish those things, but you have to be in a certain mind frame to be able to do it. And part of the challenge here, instead of trying to find those patients to become part of your practice, those patients are already there. So we just need to be able to message them and use the right mechanisms to connect with them. And so that could be a combination of emails, it could be a video, it could be doing town hall meetings, which we've all done all of these. And kind of our goal is to really reach out to as many of those past patients as possible and get them to understand the why you're doing this and why it's important for them. And direct primary care can really benefit them quite a bit. And typically, if you're an independent physician, you've been doing it for a long time, and you probably have a lot of patient loyalty as well. So, again, getting patients to understand the model, but also understand why you're doing it's really important. So again, we help build that coordinated message. But you have to be in the mindset when you're transitioning a practice to DPC. There was one specific example that I can think of right now where we had an independent practice that wanted to move to DPC. And the thing is that your patient panel reduces, your amount of staff that's needed reduces. And so a lot of times practices are really hamstrung by their office space. And, typically when a practice is, let me just put it this way. So when this practice specifically was in, medical office that was large, and now in DPC it's unnecessary. So if you were to transition a practice and keep that huge expense going, it's really going to kind of throw the DPC model into kind of a bad situation, because your overhead expenses won't match your revenues. And so the beauty of direct primary care is keeping that overhead low. I mean, it's a really simple model, so it doesn't really need it doesn't need complex solutions. So paring down that office space, getting in a position to be able to do that. And sometimes, it's dependent on your lease and your lease terms and how you're able to negotiate with that landlord to get out of that space. But then in addition to paring down your practice space to something more fitting to a direct primary care practice, your staffing has to reduce as well. And again, it doesn't make sense to employ 2 staff members per physician in this model. It's significantly less than that, or 2 or 3. And so you kind of have to have the mindset for it to all work to reduce that as well. Because in our model, it's typically with a single physician practice, it's 1 staff member to one physician. And so then you also have to pare down your patient panel. Not every patient's going to be able to come transition with you to the DPC model. Some may not just understand the model or understand the need for it. That happens. Other people can't afford it. So maybe you have those low-income people that are relying on their Medicaid or something like that, and just can't afford to transition to the new practice. You're going to have that as well. So you're going to lose some patients through the process, but again, that's kind of by design, because a direct primary care practice will cap out at 500 to 600 patients. And so a typical medical practice may have 2,000, 2,500 of active patients, maybe in the last 18 to 24 months. And so you have to think about, well, it's in this model, if you want to do it, it's healthy to be able to reduce that to maybe your core patients that really see the value in what you do and really need you as a physician. So the patients that you emerge with are the patients that really love you and really love being part of your practice and maybe see the benefits of direct primary care. So they're really good patients to have, and they're probably not going to leave you. So that's a positive to them. And then, in addition to that, we want to make sure that there's no disruption in the practice or minimal disruption in the practice. So, and that's kind of a tough part, is going from fee for service, picking a date in the future and being able to flip the switch on that date, then now you're a DPC practice and then only people that can see you are members. It's not always that simple, but we try to pare that down as much as possible to have it be minimally disruptive to the practice. And so we've been really successful in doing that. And but it's not an easy task, but it's well worth it if you decided direct primary care is the way you want to go.
Great. Well, we're going to move on to kind of the different. Oh, actually, I went too far there, but there we go. So
There you go.
Startup practice there. So this is kind of the situation that I was in. So starting a practice from scratch, and so I know this is kind of a nice thing, as you state, Jason, to kind of having a clean slate where we can pick from the beginning the correct practice location, the correct equipment, the correct staffing.
Right.
It has its own challenges, kind of really starting with no patients. So I think you've kind of worked with a few of us, myself included, in that sense as well, and kind of has a little different mindset going in this direction.
Yeah. I mean, on the positive front, yeah, you don't have any baggage that you're taking with you from transitioning the practice, meaning some of the overhead expenses. And so you're able to craft a practice that makes sense from day one. Not saying we can't do that with the transition practice, because we have done it. It's just a little bit more complicated. And so this becomes simpler. And then we're able to really craft the practice from scratch, find a location that's appropriate for the practice, find the right staff member to be part of the practice. So that's all good. And the growth of so at that point, that's the easy part. The hard part in this case is really finding the patients to be part of the practice. And that varies quite a bit from physician to physician. It depends on whether you're maybe well-known, you may have a lot of patient loyalty, or whether or not you're coming off an employed situation where maybe those patients can't follow you. So maybe like an employer clinic or something like that. The tough part is, even if you're coming from a health system, sometimes there's no solicitation clauses where you can't reach out to those patients. You have to make sure that you're as visible as possible, so those patients say, well, where's Dr. So-and-so, and they're able to find you pretty easily. So making you really, really visible, especially if you have a pretty good patient following, if you come from one of the big health systems and have a lot of patient loyalty, we want to make sure those patients can find you easily. And so that's kind of on the digital side. Sometimes practices grow a little bit faster in smaller communities too. So that all depends. It depends on the location of where you're at. Sometimes, I say that because sometimes being in a metro area, it's a small fish in a big pond and you're kind of drowned out. And so it may not be as easy for patients to find you in those scenarios. The one thing I would say, in a startup, is you have to have the mindset and be prepared for possibly a long road. And, in some cases it may take 18 months, it may take 24 months to get in a good situation with your patient base where you broke even on your practice. And again, we're structuring these practices to make sure that they're as profitable as early as possible. So that could be 100 patients as your break even, and after that, it's all profit for the practice. Sometimes it's more, sometimes it's less.
Yep. I think,
so that's really important. And those things, as far as reaching out to your community and have a growth mindset and being able to sell the practice and talk to people about it, is really, really important. You have to do that if you want to grow the practice. And it's not very hard for a lot of our physicians, because they believe in the DPC model so strongly that when you believe in something really strongly, it's easy for you to convey that message to others. And so that hasn't necessarily been a challenge. Our doctors love DPC. They love what it stands for. They love what it does for patients, all those things. So, it doesn't make it a tough thing for them to do when they need to go out and talk about it.
Yep. So just like I said, keeping your head down, keeping that growth mindset in place there. But let's talk about the third scenario there that we have talked about here. And I know this is something you are working on quite a bit, is working with employers to get that practice started. So I'm going
Yeah.
to move to
So
you.
just a quick overview. So what we're looking for is areas of demand. And the best way, the best areas of demand, or what's kind of generating these areas of demand, are pairing direct primary care with a company's benefits package. And so it's working with benefits consultants in certain areas where they see direct primary care being a really good fit because it gives them a lot more flexibility to be able to craft a plan that makes sense for those employers. In a lot of cases, reduces their cost dramatically, while at the same time giving their employees access to a physician at no cost, and it's all inclusive essentially. So it's kind of a win-win for those companies where they're able to reduce their costs as a company for their benefits package, and then provide a lot more benefit to their employees. Because you have to think about DPC from a patient perspective is very similar to concierge medicine, so they're kind of getting that level of service along with their benefits package. So there's a lot of advantages with that. But in some areas we have varying demand for a DPC practice. And so I work with benefits consultants that really, really, really understand direct primary care and see the power of it, and have had experience working with one-off practices, maybe in their communities. And so what they want to do is they want to expand it. The problem is direct primary care doesn't exist everywhere. It also doesn't exist on a coordinated scale. So you may have a DPC practice in this area of town, you may have a DPC practice on the other side of town. They don't really talk to each other, they don't use the same systems, maybe they price differently. And so maybe they have a different process for treating patients. So it makes it really difficult for those two to get together to be able to, service those employees that are part of the company. And so this gives us the ability to build a practice from scratch. So the advantages of a startup practice, but the growth is much more rapid, and it's defined. So it gives you the ability to start a practice and eliminates most, if not all, the risk of going into direct primary care. In a lot of cases, we may work with multiple physicians for one employer group and kind of scatter those practices around so people have choice. Because again, our whole thing is there's not a one-size-fits-all type of scenario for DPC. Everybody has different needs for what their healthcare looks like. And so we want to be able to provide those options. And part of that is helping these physicians be able to break through and create a practice that they feel strongly about that kind of represents them as physicians. And then so that in turn gives individuals choice of, of healthcare options for them. So dramatically reduces risk or possibly even eliminates it, meaning that a practice could be full just by launching in a certain community. And then we have opportunities across several states currently. So Dr. Patel, if you want to advance the slide. So right now, kind of a focus for us is in North Carolina. So Salisbury, North Carolina, which is about 45 minutes northeast of Charlotte. Albemarle, which is, I believe, about an hour outside Charlotte. Wadesboro, North Carolina, which is about 45 minutes to an hour east of Charlotte. And then you have Morganton, North Carolina, which is starting to get toward Nashville, and those people that are interested in kind of more the mountainside of North Carolina could be very attractive. It's a nice town. I've been there several times. And then as opportunities grow, we're always looking for doctors in Charlotte because I think that's a good opportunity for us. And then also statewide, talking about possibly even Greenville, North Carolina, kind of on the eastern side of North Carolina. But as we start filling in these gaps of DPC, and then we start seeing, having more success stories come out of this, it gives our partners more chance to go out and talk to employers that are interested in reducing their cost, just more success stories to be able to move to this model. And so opportunities for us and physicians looking to go DPC will just start increasing. But this is a mix of private companies, it's a mix of municipalities, county governments, Um, to us, it's all the same. It doesn't really matter. Benefits packages are kind of universal in that case. But we only, or I only work with benefits consultants that, again, that understand this model right now, that are really good partners for us. So these are really good opportunities for a physician to really slot in and hyper accelerate the practice and really be a win-win for everybody involved. So that's North Carolina. And then here in Indiana, where we're located, we're in Indianapolis, but Indiana is going to be a hotbed for us. And we're just getting started here, but we're looking for three to four physicians in North Central Indiana that include like Tipton, Kokomo, Elwood, Muncie, Anderson. Right now, we're looking at getting this started with, and we have a physician that's interested in where the employer is located in Elwood, and then kind of exploding that from there with other physicians in areas north of Indianapolis. And then South Bend, Indiana. So South Bend, Indiana, similar scenario where we have an employer, in this case, about 300-person group with spouses and family members, could probably be in the 500 range, where that would be a good place for maybe one or two physicians to be able to locate. And that one will probably be within the next 6 months, really be popping up. So we'll have some defined idea of what that looks like. And then also statewide. So that could be Evansville, it could be Fort Wayne, it could be Northwest Indiana, it could be the Louisville area, it could be Columbus. And so we've all had kind of some bites in those areas, and we just have to keep on, working through those. But, part of what we do is, our plan to expand this is really just broadcast these success stories with employers and get more and more people on board with it, because it's a relatively new concept, but it makes complete sense to all involved. And then, so we have Indiana, and then other opportunities. So we have Harrisonburg, Virginia could be a massive opportunity for us. It's a small town or small area, 50,000 people, kind of in the Western Virginia side, about an hour from Charlottesville, really picturesque area. But there could be a number of physicians that we could have spaces for in that area, in that general area. And those practices could be full, which is really incredible. And then Georgia, Southern Georgia, Savannah area, those are opportunities that will develop over time. And then Peoria, Illinois has pretty significant interest. And so any physician looking to, or in Central Illinois, North Central Illinois, that's thinking about launching a practice in Peoria area, or somebody that wants to stay in the Midwest, Peoria would be a really good thing. So that one just popped up recently, but there's a lot of smoke behind that. So I think we'll have some really concrete opportunities here. For us, it's really important to at least get physicians to raise their hand and say, I'm interested in these areas, because then I can go to my partners on the benefit side and say, I have some interested physicians. And so that helps the process move. If we kind of ratchet both sides up, the benefit side along with the physician side, if we ratchet those up a little bit more in sequence, that kind of helps us accelerate those faster. So
sounds good. So yeah, definitely a way of taking that risk from the startup off is working with an employer on day one. So
it is. It's incredible for any physician that's saying, hey, I've thought about direct primary care, but I've never pictured myself doing it because it's too risky. These are opportunities that really kind of are game changing for the DPC community. So I don't want to downplay that, and I'm not downplaying it. They're really, really good opportunities to really slot in and practice medicine the way you've always wanted to practice.
Yep. Well, sounds great. Well, that's all we have prepared. So we have about 10 minutes. So we are open for questions. So again, if you're on the Zoom platform, there's a Q&A section, a feature there. So you can open up and type in your question. We'll give a few minutes if people have questions for them to show up, and we'll start answering those. But our email addresses are here too. We're obviously welcome to kind of email, chat anytime. We can reach out to you independently and do that as well. So kind of whatever means works best for you, feel free to reach out, and we can talk with you. Mhm. So looks like a few people are putting stuff into the chat section there. Um, looks like there's a question about Idaho, if there's any opportunities there, Jason.
Not in Idaho. I've never been to Idaho. Not saying that there can't be. Right now it's really tough. I have had a lot of physicians that have come to me and say, "Hey, what about this area? What about this area? What about this area?" And I have doctors in areas where it's I have to find. For me, it's really important to find the benefits side of things that really sync with us. And right now, it's kind of tough. But once you find that person, they're really really they'll really accelerate things quite a bit. But um, you know,
Yeah, I know you and I've talked about this a lot. I've learned a lot about the whole benefits advising side in the last 6 months working here. And it really does take the right type of benefits broker, benefits advisor to get the direct primary care model going. So it's not as easy as just going out there and talking to someone. So we had another question about what is the average pace of growth for a new practice? So I think that it's going to vary quite a bit. Jason, I don't know if you have any kind of metrics behind that of what we've seen with some of the practices that we started up.
I mean, that's a tough one to answer. So if we're talking about, a new practice, a startup practice, again, that varies quite a bit. And maybe on the low side, we see, 5 to 10 patients a month. Don't quote me on that, but that may be, 5 patients on the low side, as the practice. So that's 60 patients a year. I think there's things that if it's that low, it's probably something's not working here, and so we need to try something different. Um, Probably 15 to 20 is kind of more likely, but it depends. I mean, it could be even more than that if that physician has a really good presence in that area.
Yeah, I would say just from personal experience growing my practice, 15 to 20 new patients a month is a good number. That's quite probably at the top end that I would want to see, just because new patients do take a little bit more time to get to know and kind of go through records and do some of that initial workup. So I think probably somewhere in that range, maybe 10 a month or so would be a great pace to start going, and that will kind of keep your practice growing, but not overwhelm you as a new physician there.
Yeah, another thing too. So one thing that to keep in mind, these practices are hyper localized. So typically when you start building a solid patient base, those people are able to talk to other people, and so you have a patient that overhears someone else looking for a doctor or maybe unhappy with their healthcare experience. That person's going to be your referral base too. So and that can happen a lot from when you start off on the employer side with employer leads. You make a good impression, which DPC does typically make a really good impression. You have a lot of people that are referral bases for you. These practices have a ton of satisfaction from a patient perspective and very low attrition. And so those are all positives. And they're clues that tell us that patients really, really like the concept, like the model, and see it being high value for them.
Yep. So there's a question about how do you approach an advisor? So that might be a whole talk all on its own. But I don't know if you have any kind of quick words.
I've yet to figure that one out.
Yeah. Well, we can, I would say, encourage you to reach out to us individually. We can definitely talk about that. I think this is the same person that is looking for someone in Idaho, but there are probably things that we look for in terms of working with a benefits consultant that is key to DPC. So feel free to reach out to us individually and we can kind of talk about that.
I have resources, groups of benefits consultants that all kind of think very similarly. So DPC, within this group may be a more popular option. There may be less of a learning curve with the benefits consultant, and so we can kind of get a head start on that. And there may be someone in your area, I don't know.
Okay. Any opportunities in the Dallas-Fort Worth area in Texas? We have a person who is opening their practice in January, so congrats on that.
Yeah.
I don't know if that's anything that we would have.
I mean, possibly. I do have some contacts in Dallas, so please email me and we can talk about it further. And I see this question here. Do you offer benefits consultants compensation? The answer is no, we don't. So employee benefits and group insurance is just a really funny thing, and not to get too far into it, but the traditional benefits advisor is someone that gets paid a portion of the premium. So they don't want to see premium go down. What we do is we kind of start reversing that. And so we want the benefits advisors, the people that really want to drive costs down low. If they were in the traditional system, what happens is they're starting to get paid less. What the people that I work with best, the incentives are aligned with the employer. So the more that they save, the more that they I guess the more they're incentivized. So there's some direct compensation for that lower cost for the employers. So the employer obviously will pay a little bit more to get costs down lower. And so that's where we want to help the benefits consultant help drive down that cost. So again, they're incentivized with the employer to get bonused or incentivized based on how the lower they can drive health costs for their employee group.
Just as a follow-up to that question, or there's a follow-up question, do we offer the compensation for the benefits advisor, or is that coming from the employer usually?
That's coming from the employer. Yeah, we don't incentivize. A lot of times there's a PEPM, so per employee per month, commission structure with ancillary benefits or something like that. We don't play in that, and we've never gotten pushback from them, but you have to find the right people to be able to do it. So it's, DPC is not a money-making thing. It's really to help the employers. And so we want to make sure that we're aligned with the benefits consultants that realize the power of us, that want to help reduce the cost for, the employers and for their employees alike.
Yep. So there's a question here about, do we work with patients that also do functional, or practices that do functional medicine? And we definitely do. We had that example in our presentation with Dr. Stock here in Indianapolis. I think it's important, Jason and I were just talking about this morning, to make sure that your practice is priced correctly for the types of visits that you're going to do. Think about, if you're in that realm, how long are you going to be spending with patients? How often are you going to see them? And just make sure that the economics of your practice match that. If that's what you're going to do. But it definitely does. And I think one of the big things that we can work on in a practice like that, when it comes to things like lab testing, supplements, medications, those types of things, because we work on finding the wholesale pricing for those and really passing on those savings to patients, they oftentimes can really value the fact that I don't mind spending out of pocket for the membership fee or coming here. I'm going to save a lot of money on a lot of that testing and stuff that we're going to do anyway. So it can definitely have great value in that functional medicine realm. So we definitely do work with those types of practices. So we've got that one taken care of. Any other questions that we have here? So do we find that most charge for labs or make it all inclusive? So I'll answer the first part of this, and Jason, I'll let you take over after that. But what I have found is it's better to not include things into your membership fee. So the membership fee includes the unlimited visits that we have in our office, maybe some simple in-office testing like a rapid strep test or a UA or something like that. And then all the digital platforms, so whether it's e-visits or telehealth, but that's what the membership fee covers. Other things like medications or labs or wholesale supplies that we may offer, those are all charged extra, but they're all done at a wholesale price. So when you show that price to that patient, they dramatically see the savings of doing that through us versus doing the retail pricing at a lab or through their insurance pricing. And so that's, I think, has been the best way of doing that. Jason, I'll let you touch on it. I think there's been some issue of, if you try to bundle too much together, we then start looking like insurance, and that then becomes a regulatory issue. And so I think that's something we want to avoid as well.
Yeah, I mean, I won't speak to that because I'm as far from an attorney as possible. But as far as including those things as part of the membership, it creates, so the problem for us is when we kind of sit down and work on financial projections, and we have a really good idea based on the practices we've launched what the expenses of the practice will be. And so, the revenue side, we want to make it as predictable as possible. So it's important to keep it simple. We contract with partners for imaging, for labs, for pharmaceutical, for vaccinations. Those things are fractions of the cost. Well, not necessarily vaccinations, but the other things are just fractions of what an individual will pay. They're passed through from Freedom Healthworks onto the practices, which are typically passed through straight to the patient. And so, not including those things necessarily, that it doesn't really, change the value proposition for someone, because those things are just incredibly inexpensive too. And it's easier for us to predict the revenue side when those things aren't factored in, because there's too many variables as far as what's utilized from a pharmaceutical or from a lab perspective, maybe things that are included. There are things that we have kind of templated that are included that should be included, like rapid strep tests and things like that. And we want to make sure, especially as we launch practices for employer groups, that there's some consistency amongst all the practices as far as what's offered and pricing. It's kind of a floor. And I talked about that kind of in the first webinar a little bit more extensively. But above and beyond that, it's whatever you want to do. We'll kind of talk you out of that as far as including those ancillary things as part of the membership, just for simplicity's sake mostly.
Yep, and there was a follow-up comment about how that would affect, that variable cost structure would affect sourcing funds for a startup. And I think that's right. I think when you talked about, if someone's looking for some funds, the financial projections we have really is based on the membership growth, not really on the ancillary services.
Yeah, and I want to address, this question, review economic issues of single and double earner families starting DPC. One thing about direct primary care that's tough for some people is benefits. And so a lot of times physicians have benefits through a spouse that works or something like that. We work with a lot of doctors that have, well, it really all depends, but we have some physicians that have spouses that are physicians as well, that are maybe currently in the traditional health system. And so that, the economics behind it really varies. Double income, family is going to be able to move towards DPC model maybe a little bit easier, because they can handle kind of the financial requirements versus a sole breadwinner family, where the breadwinner is now moving and basically creating a new business and starting from scratch. So again, it all depends. Side gigs are kind of, that all depends, because through our process, and DPC requires basically you shed all of your insurance contracts, reduce your tie to Medicare. And so that kind of eliminates or reduces the amount of options that you have as a side gig as you're ramping up a practice. But there may be some options. And we're always kind of in search for those options, whether it's telemedicine or something like that, to help kind of offset the load as you're starting a practice and maybe the phone's not ringing yet, or maybe you have most of your day still open as those patients are signing up. So love to talk about that. If you want to talk about it further, just email me and we can kind of discuss kind of what I've seen in the past.
Yep. Well, I think we've gotten to 5 past the hour here, so I think we are wrapping up. We appreciate everyone for joining us. If you have any further questions, feel free to email us. Both of our email addresses are on the screen right now. We're happy to chat anytime and talk about moving in that direct primary care realm. And we would appreciate, you're going to get a short survey after we're done here, so we would appreciate you filling that out to giving us some feedback on our webinar. We're always looking to make these informative and helping out, so we'd love to get some feedback. But other than that, I appreciate everyone taking some time today to join us over this lunch hour time, at least lunch hour.